I choose to particularly this topic because I love this topic. And for DMD student also, it was
three course session.
no, only two sessions
Two.
because it little bit long. Because yesterday only I was reading this and then I decided okay I should speak on this. So basically, whatever you do, whether you do bypass or stent or whatever, it is not permanent. Bypass is also a temporary, it gives relief because whatever graft you are taking from either a radial artery or a leg or in the internal thoracic fascia from internal thoracic artery. And that originally that artery or vein is not meant to be used for heart. But heart vessels are small in size compared to that. There is no similar arteries, but very quite similar is internal memory artery, radial and in diameter and in terms of patency.
Not from Safina's vein now.
No, I am coming to that. Oh. The whole lecture is all about that. So basically, God has created one particular artery and one particular vein for particular organ, and we are taking that and putting on the heart. God has not given any extra separate spare wheel for us, our heart. So it is not going to be a permanent, and same way stent is also not a permanent. Stent is also will give you 5 or 10 or 7 years depending on where you put a stent, how long is the stent, how is the disease burden, how much is the calcification, and whether it is near to the bifurcation or not, and what type of metal and what type of drug-eluting material is used. Depending on that, that stent will last. Today, somebody has put a stent, it is going to close 100% in a few years down the line. Similarly, if somebody has undergone CABG, the graft is going to go one day off either after 10 years, 15 years, 20 years or 30 years, but it is going to go close. So, nothing is permanent. Only permanent thing for ischemic heart disease is you have to prevent it. Okay, so prevention is totally different. So we are talking only about the graft failure. So in this is a beautiful state of the art review article. So I have taken a few days back and then I read it and cite some few points I have summarized, and we will see the current relevant evidence, pathophysiology and clinical consequences of this multifactorial phenomenon. So there are different mechanism associated with graft failure. One is thrombosis, endothelial dysfunction, vasospasm and oxidative stress. Intrinsic morphology and functional feature of this of the bypass can play a role in determining the failure. Like certain characteristic of the target coronary vessels like severity of stenosis, a diameter of the artery, extent of the atherosclerotic burden, previous endovascular intervention, whether it was plain balloon angioplasty or a bare metal stent or drug-eluting stent, and the which drug-eluting stent, that also matter. The technical factor like method, how you have harvested the conduit, vasodilatory protocol which we use on table, then the storage solution, harvest and then you put on the heart, it takes little time, so whatever time is there in that you have to store that. Then the anastomotic technique, then there are certain systemic atherosclerotic risk factor, a classic risk factor like age, sex, diabetes, blood pressure and dyslipidemia. So this article is basically in-depth. It was an in-depth article taken from Circulation 2017, and it is written by this Atlantic Alliance. Basically, this alliance is giving arterial grafting to all clients, and they have made one international consortium, and the head is David Taggart, and Mario is one of the writers who has written this publication, and it is a review article, state of the art article. So this was a brief introduction regarding this. If somebody wants this paper, I am having in my bag. So few xerox also I have. So basically, a long-term patency is a primary bypass operation and any surgery. The graft failure is complex and multifactorial event that occur in substantial portion of CABG patient over a period of time. The intimal hyperplasia and a minor graft stenosis are commonly observed in graft years after surgery. Even after 2 years of surgery, there will be some intimal hyperplasia and some narrowing will be there. That does not mean that graft is failed. Graft is considered to be failed only when there is no flow across the graft. Major contributor to both early and late occlusion remain unclear. The exact mechanism is what still we don't know. Review of current evidence on biological, technical, local factors that predispose to graft failure and evidence on clinical implication of graft failure and discuss the possible preventive strategies. So this lecture I have divided into two because the preventive part is little longer and that's the reason that it will be in the second half. So currently this is a review. The patency of different conduits. So normally we use 3, right? Gastroenterology normally hardly somebody use unless somebody is having a 4-foot amputation or amputation of both the leg and veins are not available. The even radians are positive and already one surgery done. Usually for you we use gastroenterology. So early patents, the 1 year. In 1 year, if you do 100 patient angiography, it will be patency will be this many patient, 81 to 97.9% patient will have vein graft patent. At 5 to 7 years, 75 to 86%, and late greater than 10 years, 50 to 60%. Internal thoracic artery 93 to 96%, and that is the high. It gives highest patency over a period of almost 20-25 years. The radial artery also gives quite good patency over a period of time. Now these, whatever data are there, they are mainly done in 80s and 90s. Okay, and at that time the methods of storage was different, method of how to harvest graft was totally different. After 2000, there are no new great study which can give, there are few part of the study, subgroup of that study, they have given a different, and in all that, the patency rate is far good even in a vein graft. So arterial graft can undergo reversible diffuse spasm that was string size and that can mimic occlusion, but it is not a graft failure, but subsequently dilate because of changes in the hemorrhagic condition and progression of the native disease. Meaning, if there is a competitive flow and lima anastomose to LAD, okay, so this particular distal part of the lima will become contracted, but there will be some flow or some, you can see small lumen. Suppose the stenosis goes more proximally, it becomes more disease develop over a period of time. This will open up later on. So it is not considered as an occlusion or failure.
Why there are differences in the patency of different arteries?
Yeah, I am coming to that. The whole article is on that only, that why it is different and why it is. So great saphenous vein, classically in prevent one trial, 75% at 1 year, 5 to 7 years in 75 to 86%, and greater than 10 years, 55 to 60%. And VA trial. And now these all trials were 2000 before. After 2000, not even a single good trial is there comparing the graft patency. SVG 61% and LITA means left internal memory artery 85%. The network meta-analysis compared with radial artery and right internal thoracic artery, SVG have 3 to 4-fold higher risk of occlusion after 4 years. The attrition rate of SVG is 1 to 2 years, 2% per year between the first 6 years. And after 6 years, it rapidly goes almost double, 4% year between 6 to 10 years. So honeymoon period we say is up to 5 to 6 years for a vein graft. Now different strategies are now, since last 20 to 30 years, now different strategies are started. improve SUG patency, and we are also doing almost similar, randomized controlled multiple few strategies like atraumatic harvesting technique. Now, what is atraumatic harvesting technique? You don't touch, you cannot touch vein, you have to touch vein, but you don't need to touch forceps intima of the vein with the forceps. And the forceps has to be micro instrument. They have an atraumatic tip, diamond tip, which is very, very expensive. That one instrument, one forceps is we are using German instrument is 1.25 lakh rupees. So in each surgery set there will be some 4 to 5 just a pickup. We call pickup. So that we have to use, and we have to bevel that graft in such a way that the last few stitches you have to cut that portion where you have touched. So that we use since last many years. Open versus closed technique. Now previously what they used to do is pass one wire into the saphenous vein, and here one incision, below one incision, and then they just pull. So all small branches they will tear, and after that they will manually close. So that is a very old technique. Other technique is the open technique. You open the skin and subcutaneous tissue and remove that Vaghela. Another closed technique is put an endoscope, and then you harvest with the endoscope. That is called endoscopic vessel harvesting. Now, endoscopic vessel harvesting, you have to cut with the probe, and that cutting machine is having something like 2 clips and the cautery machine. So, what happens? The cautery, whatever you use, normally near the conduit you should not use any thermal energy. Otherwise, that it will go inside the intima, and intima will damage. And because of that reason, the most of the study which compare endoscopic with the open technique, the endoscopic harvest technique, they are very poor. Even the best hands, the poor patency. Vein with fat pedicle. Now, vein usually has small fat pad next to the vein. So some people remove that, some people doesn't remove. So if you keep a fat pedicle, the basically idea is you are not touching the even external adventitia. You are just removing the fat, or you are just keeping the fat there so that it will not damage the even adventitia of the vein. Now another thing is avoidance of over distance. When you touch with anything, the both artery or vein, it will go into spasm. So when you see, when somebody has opened the skin and vein is visible, but it will go into spasm, you feel that the size is not proper. Okay. So normally what we do is we inject one small cannula into the vein or artery, and then inject saline or papaverine or diltiazem or many other vasodilator agents. Okay, and proximally we apply a forceps and then gradually distend. Now that pressure we cannot measure because we don't use any manometer. So you have to have just general idea by doing lot of work. So avoidance of over distension is because if you distend over, there will be intimal ruptures, intimal small laceration, and over a period of time it will close.
What is the comparative rate of spasm of veins in artery?
Veins will have usually they usually don't go into spasm unless it is not distended. Unless it is not distended. If it is distended once, okay, then it is okay, perfectly fine. And radial artery and internal memory artery, even if you touch, it is like Lachanika chore. You touch, it will become Turant. So then you have to again distend, and then once it starts pulsating, there is no issue. And with this new strategy, one of the good articles reported excellent long-term patency for SPG, 83% at 16 years. These results are significantly better than those with the conventionally harvested SPG and similar, and these results are equally good like left internal memory artery. Now, I remember I visited Dr. Basi. Dr. Basi is a very senior cardiothoracic surgeon practicing was working in railway hospital. So any South Indian doctor needs a bypass operation, everybody will go to Basi. And even when I was practicing in Amruta, so 10 patients is posted for surgery, 1 or 2 those who can afford, they will go to Chennai and get an operation with Dr. Basi. Now that era was like that, everybody wanted to go to Apollo Chennai. But still, Dr. Basi had excellent track record of patents. So I visited him. Now what he does, he harvests both the vein, upper se niche tak. Okay. And then he used only segment of vein without any valve. He will open both from toe, ankle to mid thigh. He will open both the sides. The whole idea is that I asked sir so much cutting and no issue. That will heal. Okay, but the graft should not fail. And one of the reason of the vein graft failure is the valve inside the vein. So these results are significantly better if you use these 4-5 techniques.
At what distances are the valves in the vein?
So it is unpredictable. Sometimes you see in 5 cm 3 valve. Sometimes you see it's at 8 cm there is no valve. So what I have observed is in the female there are more valves. Males there are no valves usually in the lower leg. Okay. And here there will be 1 perforator and here 1 or 2 perforator, and then this segment there are 3 perforators. And you have to use whether this valve is okay, you can use, or which one not. So depending on that. So what normally we do for surgery, 1 lima, 1 radial and other vessel, 1 vein without any valve. Something like that we normally do like that. But 4th graft or 5th graft or 6th graft is required. In that case we use small segment and use Y graft. Y graft is better without a vein valve. Valve with the vein. Then the one study, this is a review article, so they have taken few articles, and so they have compared that if somebody used lima and here as a Y graft SVG anastomos, and other people sometimes lima is divided here and it is used as a Y graft. So 1 year angiographic patency is same whether you use lima or whether you use SVG. But the same SVG, if you don't anastomose here and if you anastomose on the ascending aorta, the patency comes down by 10 to 12%. So basically this article suggests that even if you want to use, you don't use this segment of ascending aorta to anastomose because it's a high flow situation, and that's the reason that the patency comes down.
Sir, are we using venous graft only when we need more number of grafts, or is there any other indication where you prefer venous graft over arterial graft?
No, for this I think that there are several factors we see, whether what condition I am operating, what age group I am operating. Suppose 70-year fellow will see where I will dispenser. Whether you use vein graft, arterial graft, lima graft or radial graft, doesn't matter. 30%, 25% ejection fraction, creatinine is 1.6. This patient is not going to survive more than 10 years. Okay. So you have to assume that. Okay. Another thing is cath lab crash. Patient has given all blood thinners. Okay. And now Darshan will send to us. Okay. Now you offer emergency. In that you can't use arterial graft. Whatever you do, there will be hematoma. Whatever you touch go to internal memory artery or radial artery, there will be hematoma, adventitious hematoma. Okay. So in emergency situation like failed PTCA, cath lab crash, you will use vein grafts. All emergency normally, unless patient is having a good coagulation profile.
So in elective you will always try to prefer.
So normally 65-year-old fellow should receive at least minimum 2 graft arterial, and that too suppose right dominant. Right coronary is dominant. So lima to LLE, right coronary you put radial artery, and the non-dominant vessel you put a vein graft. Okay. Again, there are some people who has a left dominant system. take bilateral memory and harvest and put it, it will give excellent, at least minimum 15 to 20 years of angina-free life.
Some surgeons like Bhatta used to have total arterialization.
No sir, it is all wrong myth. No surgeon do like that. Okay, it is a marketing strategy. Even I do the same thing. I use only arterial graft. It's not like that. It is not possible. You have to use many times while harvesting. There is a hematoma occur. You don't have length of internal memory artery. Idea is to at least give 10 to 15 years of good angina-free life to patient, and he should not require any other surgery in the life or any other intervention. Because in India, nobody wants other surgery. Suppose a patient comes with 60 years and he wants, I want 15 to 20 years of good quality life without any intervention. Okay, my idea is I will give very good 3 main arteries arterial graft. Okay. At the most, if it is not possible, at least 2 I will give. And at the most, even if you cannot harvest, suppose radial is not takeable, at least you will use pneumothorax. I have seen patients, LAD gives 70 to 80% perfusion to myocardium. 80%. Suppose the whole heart is having 375 gram, almost 300 gram is on the left side, and the interventricular septum has got the maximum muscle. And that is supplied by left internal memory, LAD. And if you graft that, patient will not have angina. All other graft even close, nothing will happen to patients.
And what about Lima, Rima, Y?
Lima, why? Basically, Lima you harvest, okay, either you have to use on a right coronary or right PDA. Okay. But if you wanted to use multiple level on the left side, you have to give a Y configuration, so it will give extra length. And that configuration can go like this and put it on a PDA, then in between 2 OMs. So, in between anastomosis will be side to side anastomosis. Normally we do end to side anastomosis. The side to side anastomosis is little inferior to end to side anastomosis. Because one of the in between vessel get some stenosis and all the whole system will. So, our professor used to say, that when you do Lima, Rima, Y graft, okay, you are only dependent on only one husband. If one husband fails, all other wife will not have any flow. Okay. Instead of that, you put 3 independent grafts, Lima to LAD and 2 ascending aorta, 1 radial graft and 1 vein graft. All 3 will have an independent husband and independent wife, and they will have a good quality of life, at least 50 to 20 years. So, again, it depends on surgeon to surgeon, sir, how he is accustomed. Idea is the surgeon should give good anastomosis. Good quality anastomosis, which should not close at least for 10 to 15 years. So now,
is there any difference in the cost of harvesting arterial versus venous graft?
Pardon, sir?
Is there any difference in the cost of harvesting arterial versus?
Definitely, the vein, it takes only 2 minutes. Vein, take 2 minutes to harvest from ankle to knee, just 2 minutes. Whereas internal memory artery, and it does not require any other material other than the scalpel and the few silk thread. Whereas radial artery and internal memory artery, you require a good quality pottery machine or another one harvest machine is that it is very costly. Not only that, you have to use titanium clip at the both end of each and every branch, and then you have to cut it. So each clip is 75 rupees. So in one, suppose internal memory artery you harvest, you will at least use minimum 20 clips. Even if you see somebody has harvested internal memory artery and you take an angiographic picture, the clips will be visible. And by that only you can identify, now this is the left internal memory artery, something like that.
And do you check the patency and the collateral circulation of whatever artery you are harvesting before harvesting?
Yes, definitely you have to check. Suppose you are harvesting a radial artery, you have to check the Allen's test. Okay, so Allen's we do 3 ways. One is before shifting the patient to OR in Doppler, by Doppler machine, you have to close the ulnar artery and see whether the circulation is there on all fingers. And then you have to close here. Then we do on table after induction. We with oximeter we check, and again by regular method in the ward also. And before dividing the radial artery, again we check the backflow. We divide here and then check the reverse flow, whether it is complete or not. If there is not there, again we but it hardly happens. So again, recently I visited one European conference, and there I saw this device. Okay, this is a jacket of retinol. I think what I feel like that it is all complete ribbon. Okay. So what they say is if you use this jacket over the vein, there is an improvement in hemodynamic flow, and because it reduces the turbulence, and which in turn reduce the intimal hyperpressure. Now what I feel, it does not do that, but it does not kink the vein. Normally if you have a little longer vein, it can kink at some point, and that can become narrow over a period of time. But we don't have proper study at present, and we cannot use that. But it is there in the article, and everybody should know, especially student. And that's the reason that if some angiogram comes from USA or Europe, you might find that this type of jacket will be there over the SVT.
It is external.
External, yes. You just need to put it something like that. Whatever pipes recently available in the garden for gardening, similar to that. Now, internal memory artery is one of the base graft, and every patient should receive this at least to LAD. If you see Lima to LAD for first year, almost 96%, 95% patency. 5 years infused study, 88 to 94%, and recent study it is 98%. At 10 years or more, it usually reaches up to 90%, and at 15 years it is 95%. If you use REMA to LAD, right internal memory artery on the LAD, we don't have data for 1 year, but it is quite similar to this only. 5 years it is 88%, 10 years it is 81%, and 15 years it is 65%.
Why?
We don't know, sir.
Actually, what I have heard that regarding Lima doesn't go atherosclerotic changes.
Yes.
Why?
Because see,
Because of the cholesterol, HDL cholesterol.
No. What I feel that Lima, suppose if you harvest Lima, you are not dividing the proximal part. It is attached with the body. So it's a live conduit. Whereas you remove here and divide, and then you so that is called auto transplantation. Removing here and then putting there. Whereas that is a live graft. One thing is there is some neuronal connection is there which is live. That is the reason. Another thing is in intima and media there are certain changes which I am going to come on this. Okay. Because of that, usually the Lima lasts longer.
But Lima is also a live graft.
Lima is also live graft. Lima usually, sir, nobody put it on LAD, and that is the reason that we don't have significant data. Usually Lima either used as a Y graft to use for the left side, because the length will not be there, it will not go, it will not reach. And suppose you are using Lima, usually Lima is used for RCA and PDA. Now RCA is a very dominant vessel, it is usually around 3 to 4 mm in size. Not only that, wherever you put the distal RCA, it's one of the most mobile part of the heart. So it jumps here and there. You have to come and see that when distal RCA I am doing, how much it jumps. Because the tribal area is next to that RCA bifurcation. And normally we put it on a distal RCA. So that area usually you see, even if the normal vessel, there is a heavy calcification on the distal RCA. So right vessels are usually you feel very calcific compared to the left. And this RCA, if you Rima is used for RCA or PDA, the patency at 10 years is 83%. Not only that, for that particular area, even if you use radial artery or vein, the patency is not like LADs, because LAD has got very good runoff also, and at least After the proximal part of the LAD, the mid and distal part does not have usually much disease. Calcification will not be there. Usually it will be there in the first part.
So Lima has more patency at the end of 10 years compared to Lima even?
Pardon, sir?
Lima?
Rima. No, Rima does not have more patency but if you
Rima.
use, so that's what one of these articles they say Rima if you use to LAD, okay, 95%. This
That's what I
Rima
meant.
to LAD this is old study, these are new studies. In that they say even if you use anything you use for LAD, even vein graft, the patency is high. Because LAD has got beautiful runout. It supplies 60, 75, 80% of myocardium. It is going to be, even if vein graft patency at 10 years on LAD is 92%. Vein graft, radial graft patency on LAD is 90-91%. So whatever you use at 10 years, the LAD graft, whether you use vein, artery or radial, it is going to flow nicely in LAD. But yes, sir. Sometimes in some people use Rima as a free graft. Free graft they divide because it should not have a tension of the graft. So if I have a harvester and put it on LAD, Rima on LAD, if I feel before closure that okay it gives little tension, stretching for then I have to divide here and put it as a Y graft or assembly graft. If you do that as a free graft, the patency comes down by 4 to 5 years. So if you use as a pedicle graft, the patency goes by around 4 to 5 years. So always
Take both Rima, Lima, and the healing of the thorax.
yes, then because the sternum is usually supplied by internal thoracic artery, and not only that, and from the shoulder girdle there is one more few vessels are there. So normally, if the patient is not obese, not severely diabetic, no COPD, okay, and the sternum is not osteoporotic, you can safely harvest both. And now when you harvest the internal memory artery, at that time you don't need to take a big chunk of tissue around internal memory artery. You have to harvest, we call it a skeletonized lima. Skeletonized lima means you should not have much pedicle. You have to go very near to the internal memory artery and harvest so that thorax will not have much thermal injury, the chest wall. If you use more cautery on the chest sternum, okay, it is not going to heal, okay, and then it will give dehiscence or mediastinitis. So this happens when somebody has used nowadays because most of the surgeons use harvesting with the harmonic scalpel and they are using we normally all young surgeons they are using skeletonized lima. So usually damage to the thorax and sternum will not be much. We use very minimal use of cautery when we are harvesting the internal memory artery. Only few areas if there is some oozing is there, just pinpoint that area and then that only will give thermal energy. So Rima on RCA, PD or OM, wherever you put it gives so poor patency compared to Rima to LAD. The possible cause is competitive flow, dominant right or left. LAD has better runoff. Okay. The Rima free graft on PVA or RCA has better patency than the it is pedicle graft. I don't know why Rima pedicle graft has got less patency compared to free. I personally feel that it most probably it is related to stretching of the right internal memory artery pedicle. Now radial artery, the 1 year patency is 89 to 92%, excellent patency, 5 years 90 to 98% and 20 years 83%. The attrition rate is 0.4% per year after first year up to 20 years. So that is also excellent compared to a vein. There is a 25% probability for occlusion at 20 years for RA, 19% for Lima and 55% for SVP.
Sir, how this patency percentage is defined?
This. Basically, you suppose if in this particular year I have operated 100 patients, all patients I do angiography, 89 to 92% patency means out of this 100, 8 to 10 patients, they have closed radial artery. That is called patency.
Closed मतलब completely occluded.
Closed failure. Graft failure means 100%. There is no flow across that graft, either as distal end, proximal end, and or in between or total. There should not be any flow. If there is some flow, that means it is stenosis, not occlusion, no failure. It can be stented or it can be some vasodilator agent you can use. At 5 years, 90 to 98%, and at 20 years, 20 years, all same patient angiography done. Okay, and then you see that almost 83% radial artery is patent, and remaining 70% the radial artery is closed. So at 25% possibility at 20 years, and 19% for the lima, and 55% of the patient SVT will be patent at 55%, 45% patient will have a patent. There was a trial called RAPCO in 2016. The 10-year patency for RA is 89 to 91%. Now, important predictor for patency for RA means radial artery, is severity of the proximal stenosis. Now, what do you mean by that? Suppose there is a stenosis here which is 50%, and the 50% there is a flow, and if I put an arterial graft, that graft will not work. 100% will not work. Within 1 month only that graft will close. That is because of the competitive flow. But same thing, if it is 90% stenosis, means critical, more than 70%, if I use arterial graft, it is going to flow like anything. And it will become distended, and nicely, if you see angiography, you will see the lima or radial, it is distended nicely and it is flowing nicely and with PVC flow. So,
see, radial artery, how the patency increases from 1 year to 5 years?
these are, sir, basically what I have done is multiple articles. They have reviewed articles. This is basically a review article. So what they have done is multiple articles are there. So they have taken an average of everything, and then they have given the data, something like that. So whatever data we have, these are the things: 89 to 92%, 90 to 98%, then 83%. I also had a doubt that why here there is an increase in that. But basically it's a meta-analysis of many studies.
So it's not necessarily the same patient in 1 year that you
see. This is not a Vipul Vaghela, Sahib Pankaj Bhai ka data hoga ya Rajesh Bhai ka data hoga, something like that. So different वो लोगों ने consolidated an overall picture there.
Regarding radial artery, most of the angiography are now done through the radial. Does it affect your RST?
Yes, we should not use that. We don't even use that.
So
when anybody has punctured radial artery for even ICU for the arterial line purpose, we don't use. And that's
the ABD is multiple times,
it should not be done, sir. It should not be done. It should be done with the femoral.
They use left radial.
And we in our cath lab, in cath lab, they have standard instruction: nobody will touch left-sided radial. Nobody will touch. They will use only right radial. Correct?
Yes.
what about ABG?
ABG or femoral, or if they have an arterial line here, from there they can do that. ICU patient will have arterial lines. Femoral arterial line or radial arterial line. So from there,
Yes, sir.
where you are taking IBG?
Mostly femoral arteries.
Because sir, for surgery we put 3 arterial lines. 2 here, both the femoral and 1 radial. Okay. Left side we don't touch, because if we are harvesting, we should not touch the radial. Okay. So this we use after mobilization of the patient for arterial purpose, ABG purpose and monitoring of the. This femoral 2 cannulas, for one for a pressure study and another is for emergency IMP insertion. Suppose we are doing one beating and a patient is crashing, we put a IMP. If we have a line, we can put it immediately. So For ABG purpose, I think femoral artery we normally take.
Do you use both the radial artery or grafts?
We can use both of them. Nowadays in India, sir, in Baroda only I have now 17, 18 years. Sir. Since many years, I have not seen somebody doing femoral angiography. They are using radial artery. Hardly some redo procedure or some already done once, and the cardiologists are not used to first time they are doing, and sometimes the radial goes into spasm or hematoma. In that case only they are using femoral. Otherwise, most of the cases right radial is gone before they come to our theatre. So normally
More than 90%.
not more than now 98%. How many last month? How many femoral angiography?
Hardly 10.
Very rare. And
Very rare.
And in US, getting a radial done is a problem.
Is a problem.
And I had to ask for an Indian trained person 1.5 hours away from the patient's town to get a radial angio done.
Yeah.
So it's a reverse thing. They are still going ahead with only conventional and femoral.
Yeah. But there should be something like that. You inject only in the vein, like CT angiography. You inject in the vein, dye, and then you take a picture. Okay. It should come like that. So then there is no, you don't need to insert through up to the coronary. You just inject in the venous system, and then you should have all the pictures. I think that hybrid CT angiography plus ऐसा कुछ machine आएगा एक दिन. Right gastroabdominal, sir, I do only once, and that was one redo patient, and that was my boss harvested and I assisted him. So I don't have much experience, but yes, for academic purpose, it has got very limited data. The 1 year patency is 92 to 97%. Now, the stomach and this is greater curvature of stomach. So this right gastroabdominal we have to harvest, and with the fat pedicle. And from the diaphragm small hole, and it's basically a pedicle graft. It's not a free graft. And you can use, usually it is used for a PDA or RCA, not for LAD, but you can use for LAD also. It does not go up to OA. 5 year patency is 80 to 90% and 10 year patency is 62%. Only few data we have. What is the time?
I think you should continue in the next.
Because this is a very long lecture, so we
Already 9:35.
so we will conclude, and so we will do in 3 sessions. Second session I will take the biological mechanism, and the last is the most important is preventive part. So this article is supervised. I will send it to